Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm pleased to welcome you to the multimedia summary for the journal's March 2020 issue. There are 3 articles that have been selected as our Editor's Choice or Highlights articles this month. Our Editor's Choice is an original article entitled The Association Between Perceived Electronic Health Record Usability and Professional Burnout Among U.S. Physicians. The article is authored by Dr. Edward Melnick and colleagues from Yale University School of Medicine in New Haven, Connecticut, Mayo Clinic in Rochester, Minnesota, the American Medical Association in Chicago, Illinois, and Stanford University in Palo Alto, California. Physician burnout is both tragic and costly because it vitiates a dream and a career achieved only after years of sustained dedication and accomplishment. Superior GPAs and MCAT scores and hours of physician shadowing and community service to secure acceptance into medical school, 4 years of demanding medical school training, 3 or more years in residency, and subsequent years during fellowship and subspecialty training. The fallout from burnout goes beyond the physician so afflicted to envelop patients and patient care, medical centers, and the healthcare industry. These far-ranging effects of burnout have led to substantial efforts to delineate the basis of this malady and ways it can be mitigated. Consistently identified as a salient contributor to burnout is the electronic health record, ironically a computerized system introduced in part to improve patient care and professional satisfaction of physicians. General attributes of the electronic health record that may engender burnout include its mechanical engagement that detracts from the direct patient-physician interaction, its ubiquity and tenacity that rarely leaves the physician free of administrative obligations, requiring completion within a constrained time frame, and its catalytic effect on enabling highways of communication that may not be necessarily relevant to patient care, but nonetheless requires an expeditious response. The electronic health record currently requires approximately 2 hours of electronic health record-related work on personal time after each working day. This denies physicians such personal time that regenerates their sense of vocation and purpose and makes them fresh and ready to embrace a new working day. But what about the intrinsic usability itself of the electronic health record, in addition to its general attributes as a cause of burnout? Melnick et al. Addressed this question in the present issue of Mayo Clinic Proceedings by cross-sectionally surveying U.S. physicians from all specialties using the American Medical Association Physician Master File. Usability of the electronic health record, broadly considered, was considered by the System Usability Scale, a straightforward, reliable, and validated 5-point scale, 10-item questionnaire that evaluates the usability of technologies, products, and services. Burnout was assessed by the Maslach Burnout Inventory, the latter in long-standard use and also reliable and validated. The data demonstrate that while there were substantive differences in electronic health record usability across specialties and practices, the mean SAS score of the electronic health record reflected its usability falling into the not acceptable range or earning an F grade. To put this into context, and as pointed out by Melnick et al. In Mayo Clinic Proceedings, this F grade places electronic health record usability way below, for example, Microsoft Excel, which in prior studies of usability of products in common usage received the least score and graded as low marginal in the acceptability range. Moreover, on multivariate analysis and after adjustments for relevant factors, Melnick et al. Demonstrate that such poor usability of the electronic health record is independently associated with burnout in a dose-dependent manner. While this study is based on an association and thus cannot speak to causality, it seems likely that poor electronic health record usability contributed to physician burnout, rather than a greater proportion of physicians with burnout evaluating the electronic health record more harshly. Supporting this premise is the fact that the electronic health records often received better scores from certain specialties more predisposed to burnout. The electronic health record is a relatively new technology that is here to stay, and as for all new technologies, will likely improve with time. Patients and patient care, physicians, and healthcare systems deserve an electronic health record that is far better than one with a failing grade. The importance of the study by Melnick et al. Is that it uncovers how low in usability the electronic health record ranks among products and services in daily use, and its dose-response association with physician burnout. The voice of the physician in evaluating the usability of electronic health records needs to be heeded in guiding the improvement of this evolving technology. Our first highlight article is an original article entitled Dose-Response Effects of Exercise on Glucose-Lowering Medications for Type 2 Diabetes, a secondary analysis of a randomized clinical trial. This article is authored by Mr. Christopher MacDonald and colleagues from the University of Copenhagen in Copenhagen, Denmark, and other hospitals and institutions in Denmark, Sweden, and the United States. The health benefits of exercise have long been recognized, and indeed approximately 2,400 years ago, Plato wrote, "Lack of activity destroys the good condition of every human being, while movement and methodical physical exercise save it and preserve it." A vast body of contemporary literature attests to the diverse health benefits of exercise that range from protection against cardiovascular diseases to the reduction in the risk for cognitive decline and depression. Yet a sedentary lifestyle continues to markedly increase, both nationally and worldwide, and is implicated in the rising global incidence of many chronic conditions, including type 2 diabetes. In the present issue of Mayo Clinic Proceedings, MacDonald et al. Examined the effects of exercise on glycemic control in patients with type 2 diabetes less than 10 years in duration, specifically questioning the extent to which exercise may lessen the need for glucose-lowering medications. This study is a secondary analysis of a randomized controlled trial of exercise in patients with non-insulin dependent type 2 diabetes. All patients received standard care that involved medical and lifestyle counseling periodically over 12 months, and predetermined algorithms were used to determine the dosing or cessation of glucose-lowering medications. Glycemic control involved a target hemoglobin A1C of 6.5%. All patients received standard care that involved medical and lifestyle counseling periodically over 12 months, and predetermined algorithms were used to determine the dosing or cessation of glucose-lowering medications. Glycemic control involved a target hemoglobin A1C of 6.5%. 31 patients received standard care, while 61 underwent supervised exercise and dietary guidance, the exercise volumes being divided into tertiles. Exercise and physical activity were monitored by electronic devices and thus not assessed by the less accurate self-reporting as is commonly employed. The data demonstrate that all tertiles of exercise volumes were associated with an increased likelihood of discontinuing glucose-lowering medications, and for the intermediate and upper tertiles, beneficial effects were observed for cardiovascular risk factors such as cardiorespiratory fitness, serum triglycerides, hemoglobin A1C, and 2-hour glucose. Such indices, to the extent to which they are impaired or elevated, may be harbingers of cardiovascular and/or diabetic complications, thereby providing added evidence for the beneficial effects of exercise in type 2 diabetes. Whether such exercise volumes can be readily incorporated into and sustained in patients' lifestyles is uncertain. However, it should be noted that the more recent guidelines for physical activity in adults as published in JAMA in 2018, as compared with prior guidelines, call for increased activity, and these include either at least 150 to 300 minutes per week of moderate intensity aerobic exercise or 75 to 150 minutes of vigorous aerobic activity. Alternatively, a proportionate admixture of both types of activity may be followed. Additionally, strength training should be undertaken at least twice per week. The lower tertiles of exercise volumes in the study of McDonald et al. Thus approximate more recent guidelines for physical activity. It should also be noted that exercise is relatively free of charge and adverse effects, whereas glucose-lowering medications impose the risks of assorted side effects and costs. McDonald et al. Thus demonstrate that exercise may obviate the need for glucose-lowering medication and decrease relevant risk factors in a dose-dependent manner in type 2 diabetes. And the second part of Plato's antithetical statement clearly applies to type 2 diabetes. Our second highlight article is an original article entitled, "Is My Patient Overwhelmed? Determining Thresholds for Acceptable Burden of Treatment Using Data from the Compare E cohort." The article is authored by Dr. Viet Thai Tran and colleagues from the Centre de Recherche d'Epidémiologie et Statistique Sorbonne, the Assistance Publique Hospital de Paris, and the Paris Descartes University, all in Paris, France, Mayo Clinic in Rochester, Minnesota, and Columbia University Mailman School of Public Health in New York, New York. Chronic diseases and multimorbidity are increasingly prevalent for at least two reasons. First, the aging of the United States and worldwide populations steadily continues, and age is one of the major determinants of chronic diseases. Second, acute diseases in general are now more effectively treated, with an attendant reduction in their mortality, thus leaving in the wake of such success the emergence of chronic sequelae of these diseases and their treatment. The management of chronic diseases involves multiple strategies and interventions, which in their full range impose on patients what is now described as the burden of treatment. In their seminal analysis more than a decade ago, May, Montori, and Mayer defined the burden of treatment as the work of being a patient, and called for minimally disruptive medicine as a model that can mitigate such burden and work. In-depth and persuasive analyses, such as, for example, by Tran et al. In 2015, delineated the extent and weight of this burden that include patient healthcare responsibilities such as education, alterations in lifestyle, non-pharmacologic treatment, medications, follow-up, paperwork. Issues that exaggerate the burden of treatment, for example, impaired access to and poor coordination of healthcare, considerations that are personal, situational, cultural, and financial. And finally, adverse effects of healthcare responsibilities that include such considerations as non-adherence, undesirable effects on personal and professional life, and exacting financial cost. In the present issue of Mayo Clinic Proceedings, Tran et al. Determined what is an acceptable burden of treatment by evaluating patient responses to the treatment burden questionnaire and by a yes or no answer to the question regarding the sustainability of the current amount of care expended by the patient. The patient population involved the Community of Patients for Research, an e-cohort of patients in France with chronic conditions. The authors adopted the patient acceptable symptom state for assessing the burden of treatment. This was defined as the treatment burden questionnaire score, under which 75% of patients were accepting of their burden of treatment. Remarkably, approximately 38% of patients with chronic conditions in this survey viewed the burden of their treatment as so daunting that they felt unable to cope with the treatment plan in the long run. Additionally, the authors provide a tool, the patient acceptable symptom state, for the burden of treatment that aids in identifying patients who are at increased risk of not coping with the demands of their medical care. The findings of Tran et al. Thus advance the field by demonstrating the extent to which patients may regard the burden of their treatment as unendurable in the long run, by introducing a simple index that may identify patients in whom the capacity to cope is increasingly tenuous, and by broadly raising the issue of how the burden of treatment imposed on patients may be modified and or lessened, such that the burden of their illness is more effectively addressed, more readily accommodated, and more serenely borne. You can access these highlights and editor's choice articles free of charge during the entire month of March when you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org. You'll find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings issue summary and author insight podcast recordings, which are available from our website on the home page, as well as through iTunes. You will also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who have made a strong impact in their field of study. You will see many news stories on our website that are based on articles published in Mayo Clinic Proceedings. And finally, you'll see other free content and articles published online ahead of print. As always, we greatly thank you for your interest in and support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.